So I wanted to now switch to Marty Charns. Marty spoke yesterday. He's the director of the Center for Organization, Leadership, and Management Research, a VA Health Services Research and Development Center of Excellence. He's a professor of health policy and management and director of the program on healthcare organization studies at Boston University School of Public Health. He has over 35 years' experience in the field of organization, and he claims he's the only DBA in the room. Thank you very much for participating.
For better or worse, you got me twice. I'm going to talk about the Yano paper first, and then the Devers paper. So Becky and I, as you probably could tell hearing us talk, work kind of in the same sandbox. I very much like the work she does, and think the paper makes a number of very important contributions. I just wanted to highlight 4 things that I thought were real strengths, and those of you that I don't think people got the whole papers, but I think it's important to pay attention to several things in this paper. First off, there is support through the various presentation and discussion around the importance of multi-level studies. Another important point is that the paper distinguishes between efficacy and effectiveness, and it's not the only paper, obviously, that does that, but it so much is an important point and puts so much of the emphasis on how critical the implementation process is and the importance of context. The examples in the paper, which Becky cited, were a central part of what they saw as their objectives in putting the paper together. I think really are a major contribution. I'll talk in a minute about some things I'd like to see them do in their final version that would extend that. But they're very good examples. They're very informative. And in the paper, they also talk about the theories that were used in those different examples. And that's something we mentioned yesterday as being important in some of our discussion, and as something that often is lacking, being the explicit identification of the theories that are being used. Some things that I'd like to see greater emphasis on is that I didn't see a lot of discussion, and I actually saw a little bit of interchange of words around adoption and implementation. So an organization can decide to adopt a new practice, but that doesn't mean they actually get it implemented so it works. And that whole process of implementation is largely what was talked about in Becky's presentation. But just to make a little bit more distinction between those 2 different things. Sustainability is probably the biggest bone I have to pick with her paper, and perhaps we just look at it as an honest disagreement. I agree that you don't want to sustain something forever because then you never move on to better stuff. On the other hand, if we don't have some degree of sustainability, if not the exact practice, at least the gains that we've achieved through the implementation process, if we don't have that, then at best, we've wasted energy and we've slipped backwards. And at worst, what we've done is raise people's expectations that things were better, but now we lost it. So the next time we try to implement something, they're further disillusioned about the change process. So I'd like to see a little bit more balance to my colleague around the issue of sustainability. Also, discussion of spread. I think it's important to differentiate between spread within organizations and spread among organizations. And it's the same concept, but I think some of the issues that come into play, because they're at different levels, may be different. And we might bring in, where's Arnie? Arnie's on that side. We might bring in the idea of organizational field that Dick Scott raised yesterday when we're talking about the spread across organizations. And then a little bit more, of course, you didn't all read the paper, but a little bit more of the descriptions of how the mechanisms worked. You've got such a rich set of examples here, and you'll hit against the page limit for the paper, but that's something that I think we could benefit from. Raised a couple questions for me. The first one is the levels in the studies. Are they really all multi-level? Certainly they're 2-level, but are they all 3-level? I maybe missed it and missed it in the paper, but Becky cited it in the presentation that there was a practice level intervention in the Harvard Vanguard example. And this again raises the question that I raised yesterday in our presentation as to whether patient and provider represent 2 levels or not. And I know from an analytical perspective, when we do hierarchical linear modeling, we often cluster patients by provider and then providers within practice, if we can cluster as many levels as we wish we could. But so that's one argument to say they should be separate levels. But there's another argument which really said providers and patients really are both individuals at the same level. So I think that's a debate for us. How do we identify levels? And might we describe more about how interventions interact? So this particular paper within organization. So if we look at the VA, the VA is an organization. So is that it? Is that a level? Well, this paper went beyond it to say medical centers in the VA are nested hierarchically within VISNs, Veterans Integrated Service Networks, or regional networks. And what was happening at the network level, the incentives, the measures, the leadership, are important for what happens at the next lower level of the medical centers. So this was a good example of where within what we've called kind of loosely one level in our multi-level diagram, where it's important here to differentiate among those levels. But I think the important question for us as we move forward in this area is how do we distinguish among levels? The question is, what makes a level? I don't have the answer to that, and it may be totally dependent upon the specific situation being studied. It's triggered another idea. Becky talked a lot about implementation, about PDSA cycles. And so I thought one of the things that might be useful for us to think about is that sometimes what we're trying to do, if you look at the left side of my continuum here, is implement an evidence-based practice. And in some ways, it's a push strategy. We have evidence, we have a practice, we want to push it out into the field. Now, of course, we know that you have to adapt the practice to the particular setting. And one of the concerns is, as you move further and further towards the right of the continuum, as you're adapting it, at what point have you lost what the original practice was that you were trying to implement? So there's this question about maintaining fidelity that you have to look at. Coming from the other side, often organizations start with quality improvement. So the issue is they begin with a problem or a process that they want to improve. It's a pull strategy in terms of trying to bring in evidence to help do the improvement. And, there's much more flexibility in terms of what's going to happen. Well, I think the examples provide, some mix of that. And I think as we think about implementation, because I know organizations use both of these ends of the continuum and blends in the middle, that we think about what is being used and what are its characteristics. Slight plug, actually I'll build off of this in a minute. This is the organizational transformation model that my colleagues and I developed to look at organizational improvement. I just want to highlight a couple things in it. If you're really interested in it, the URL is OTM for Organizational Transformation Model at BU for Boston University.edu, otm.bu.edu. You can find out everything you want about the model. There's a journal article also. If we look at this, you'll see on this diagram two things I want to point out. One is leadership. And what we've found in our work is that leadership is important not only at the top of an organization, but right down through frontline supervisors to the front line, a multi-level concept, if you will. And also you see a vertical arrow on the left side of the diagram called alignment. And that also is a multi-level concept, and it's something that while Becky didn't refer to it explicitly, she did refer to it implicitly in the paper, how at different levels of the organization are things supporting rather than providing barriers for the next lower level. I'm going to move on. Importance of context for implementation. Is that what I got left?
Yep.
Oh, fine. I think that as we look at the state of our science, we know we're learning a lot about implementation. I think one of the things that still, I'm pushing the same concept here, that still we're lacking is a lot of knowledge around sustainability. We know the importance of things at the organizational level of culture and leadership support, both for implementation and sustainability. So to pay attention to those things as we're looking at multi-levels. Moving on to the healthcare reform, obviously this is probably the biggest change I've seen in my career in this field. One of the things I think that this does is present a wonderful opportunity for research. And the reason is that there's going to be not only change to look at over time, which is one aspect, but also, as Kelly described it, there's going to be variation in the way organizations implement their specific changes. Now, a suggestion for this particular paper, or if it's not going to go in the paper, then I think it's something we need to do, is look specifically, do a very detailed analysis of how healthcare reform and the different parts of it are going to directly affect the different levels in the multi-level model. So Kelly referred to effects at different levels. I don't know that I'm smart enough to figure out what those effects might be, but I think it would be useful to do that, to think that through in a detailed level in advance. Similarly, look at what happens at the interactions, or analyze what we think would happen, and what will happen. So look at the multi-levels and look at the different types of care along the continuum, so that we have a more detailed analysis of what we anticipate the impacts would be. Those could give us some propositions to test. I agree for the need for big science, because I did go to business school, I guess. I think it's important that we have a balanced portfolio. And right now, the part of that portfolio that's unbalanced is we don't have enough big science for addressing this. So I think it is important to do, not that we would do no individual investigator-initiated work. I think it's necessary because it's an opportunity that is going to pass. And if we can't move quickly to do research on it, we will miss this opportunity to learn. We need some common measures. It's been talked about before. The electronic health record may help. Organizations that have those already in place have a wonderful tool to use for research, but organizations that are just starting to implement, we know the implementation is going to take too long to be able to have the data available for us the way those that already have it in place would be able to do. The importance of multi-method work, testing propositions, identifying contextual factors, which largely is probably going to be qualitative work, and identifying factors for additional study. I want to urge us to look at this over time. It's going to unfold. It's a wonderful opportunity to study the processes of implementation. It's not a steady state where we're taking a snapshot, but can we look at the dynamics? And finally, my final plug, don't forget the history. You know, that all organizations are not starting at the same place as they implement, you know, their ACO or their patient-centered medical home. Thank you.
Thank you. Thank you, Marty.